All right, we have the chairs set up thanks to the crew. Good stuff. We have one more panel discussion before break, so hang in there. And that was a really interesting discussion that we just had with Mark Del Monte and Paul Grundy. So as we transition now to another really important topic and talk, just a little bit of background for you. We referenced a few times NASEM. And the NASEM recommendations, in some of the NASEM recommendations, it focuses on investing more in primary care through hybrid payment models. And the panel that we have next is going to consider some of the lessons learned from CMMI models and also highlight public and private payers in this context of the NASEM recommendation, and importantly, how health equity is being considered. So I'd like to welcome to the stage my fam, Doug Jacobs, Crystal Eubanks, Nate Murray, and Ryan Schwartz.
I grew up as the middle child, so it's just my natural landing spot. So really so honored to be here today and to lead this important conversation. I know for a fact that some of the panelists have been chomping at the bit to have this discussion. I wanted to just level set for us. You know, we've had lots of references to the NASEM recommendations today. And just to review for you the context for this discussion, that set of recommendations that focus specifically on payment reform for primary care to support modernized advanced primary care was quite concrete, right? It had specific elements in it about moving payment from primarily fee-for-service to primarily, at the very least, a hybrid of fee-for-service and capitation. That would allow primary care practices the flexibility to tailor care to individual patient needs without concern for billing units, and also invest in the kinds of infrastructure and resources they need to meet some of these. I have to say, you know, just listening to the first two panels and the conversation, these are very, very deep expectations of primary care. They just seem to grow over time. They don't actually seem to move in step with payment. And so there's a real disconnect there. So NASEM talks about this transition from fee-for-service to a hybrid, more capitation, but it also talks about the prices that are set on that payment and calls for an increase in investment in primary care in absolute terms by at least 50% relative to where we are today. You know, in Medicare, we'd be going from 3% of spend to 4.5% of spend. Really, it doesn't sound overwhelming, but that's a starting point from the committee's perspective. And they couple that with a call to really rethink how we hold primary care practices accountable. There was not an emphasis on having practices accountable for total cost of care. There was an emphasis on having practices held accountable for some of these new expectations, like addressing social drivers of care, of being able to provide team-based care, community-oriented care, and importantly, responsive to a set of quality metrics that was concise and meaningful, which is not what we have today in the current measurement industrial complex. So that's the context in which I am really honored to try to facilitate this conversation from four very influential stakeholders. We have Doug Jacobs from the Center for Medicare at CMS, and who is responsible for advising on quite a range of issues, but especially around value-based care and payment policy. We have Crystal Eubanks from the Pacific Business Group on Health, who is going to share some about her new exciting initiative and what that may hold for models in terms of approaches to primary care payment. We have Nate Murray from Crossover Health, who's going to talk about what his primary care group is doing in terms of innovating on payment arrangements, especially in direct arrangements with employers. And then we have Ryan Schwartz from the Mass Health Authority, who needs to remind us, because we need reminding, that we can't leave states out of this conversation. States are incredibly influential. They're right on the ground with their communities. They can't escape them. They don't have a Congress standing in the middle. And they serve some of the most needy populations. So with that, let me start by turning to Doug, who has the window seat. And Doug, if you could share some about the new strategies that CMS is taking, especially in payment for primary care, especially within some of the value-based initiatives, but then also in other programs like Medicare Advantage or...
Yeah, absolutely. First of all, it's just such a pleasure to be here with all of you. And this is an area where we're definitely thinking very hard about how we want to move forward. And it's not just the Center for Medicare, but we're thinking about it across CMS, across HHS, as you heard earlier from the Assistant Secretary Levine. And it's an area where we think we can go further together, not just siloed. And so with that in mind, some of what we've set forth in terms of our value-based care goals, because we talked about some of the challenges with fee-for-service, is really by 2030 getting to 100% of traditional Medicare beneficiaries in an accountable care relationship with their provider. And the reason, and primary care is just foundational to accountable care also. So when we talk about accountable care, we're really talking about primary care too. And just to illustrate that point, every year we come out with accountable care organization results. And this last year, those ACOs that have 75% or more primary care doctors, compared to those ACOs that had less than 75%, actually had a savings per capita of $280 compared to about $140. So there's almost a doubling of savings per capita in the Medicare Shared Savings Program. So the Medicare Shared Savings Program, just to take a step back, it's the largest accountable care program in the country. And there's close to 500 accountable care organizations. More than 11 million people with Medicare go to one of these ACOs. And what we're really trying to do is grow this program significantly in Medicare, and think that will pay dividends also in terms of the really focusing on primary care as part of this too. So just to give an example of some of the changes we're making, we recently created some new policies to make enhancements to the Medicare Shared Savings Program with some of this care transformation in mind. So what do I mean by that? Well, just beginning of last month, we came out with this rule, and we said, so new ACOs that are forming will be eligible for what we call advance investment payments. Very similar to what Mai was just talking about. These would be upfront payments that new ACOs could use to invest in provider staffing. We've heard loud and clear that provider staffing right now is exceptionally challenging. Hire community health workers, hire behavioral health clinicians, integrate as part of that ACO and primary care network. Also, they can use these dollars to directly pay for social needs of Medicare beneficiaries. So linking together food insecurity, housing insecurity services, whatever those might be, to get towards this more of an idea of holistic, whole person care. And then the third piece is infrastructure, so, some of the infrastructure needed to succeed in accountable care. And so these payments, this is one of the first times that we're kind of divorcing the payments away from the typical fee-for-service payments and saying they're eligible for all these new things. And we're interested to see, we think that more ACOs can form in particularly underserved areas, and B, that we're really excited to see the ingenuity of the flexibility, like once we create this flexibility, how do providers on the ground, including mostly primary care doctors, take advantage of these new payments? So that's the first piece. Oh, and also with those payments, for those ACOs that treat underserved communities, they'll get more payments to potentially invest in this infrastructure. The second piece I wanted to maybe just touch on, just kind of going away from the value-based care goals, and we can return to those, but also in thinking about this idea of whole person care, we're looking at the fee schedule. A lot of the benchmarks that accountable care organizations and their financial methodologies are based on, they're actually based on this like fee-for-service type system. And so making changes in the fee-for-service system is still important while we move towards this vision of moving towards value-based and accountable care. So we've also created some new changes to allow for clinical psychologists and licensed clinical social workers to provide behavioral health services as part of a primary care team. We're calling the new code behavioral health integration. We're also saying that there's a lot of supervision requirements in Medicare, and we've also said that for behavioral health services, the physician or non-physician practitioner doesn't need to be physically on site for when those services are being performed. And this is for, say, there's a licensed professional counselor, marriage and family therapist, certified peer recovery specialist. These are all providers that really can help provide behavioral health services as part of a primary care team. And so we're trying to advance that as well. So the last piece I wanted to mention, because you brought this up, is we're really trying to think about alignment of quality metrics across our programs. And this is it's just so important because I think a lot of us have probably been in the situation of being held accountable from different payers for different quality measures. I'm actually a primary care doctor as well. And so what we're trying to do is think not just within Center for Medicare, but across CMS, how do we align all of these measures so that providers can really focus on the most meaningful measures and making and improving their care that they deliver. So keep a lookout for that going forward. And finally, just to maybe tie it all together, this is all part of the larger initiative to strengthen primary care that we're working on that Admiral Levine talked about earlier. So.
Thanks, Doug. So we'll come back to some of those themes, but let me now turn to Ryan. And Ryan, could you bring the state perspective to this? Can you talk? I think many of us are very excited about Massachusetts' new 1115 waiver. Can you share with the audience some of the details in there that really relate to primary care payment?
Sure. Thanks, Mai. And thanks, Doug. So for those of you, Medicaid policy, an 1115 waiver is the federal authority for a state to implement kind of an atypical or an innovative Medicaid demonstration. Massachusetts has had an 1115 demonstration going for 27 years now. And starting in 2018, we transformed about 80%, 85% of our managed care eligible lives into accountable care organizations in Medicaid. And that was a huge, huge transformation. However, to Doug's point about the fee-for-service chassis, one of the challenges with that initiative was at the foundation of the rates build-up for our accountable care organizations, much of it was still based off of a fee-for-service payment mechanism. And so in September, our newest 1115, which started in October and goes for the next 5 years, we will start to capitate all primary care across the state for Medicaid, which is, thank you to CMS, the first time this has ever been done in Medicaid. And one of the important aspects of this, a few important aspects. So what is the program? So we will be paying provider systems a prospective PMPM. Importantly, there is a substantial rate increase to all of the points that have been made previously today about the importance of increasing the investment and the actual percentage of the total cost of care that's going towards primary care. We are very much putting our finger on the scales and tipping that balance in terms of the rates. So primary care rates in this program will be substantially greater than historical previously. And provider systems will be able to anticipate on an annual basis exactly what their revenue will be on a month-to-month basis. And the precedent-setting piece of it from a CMS perspective is that we will not be reconciling to volume at the end of the year. And this is, from our perspective, a critical aspect of the program that enables us as a payer, but also, more importantly, our providers. I also work in a community health center in Boston, so like Doug, to really feel like you are actually starting to be decoupled from the 15-minute fee-for-service treadmill. And so we are launching this program in April. Our hope is that it does start to push forward a lot of the discussion across the Commonwealth, Massachusetts. Massachusetts is a Commonwealth, not a state. Geeky trivia. Anywho, but our hope is that this will really start to push the needle on payment reform at the state level as well. And what I mean by that is saying, when we think of our influencing power as a payer, Medicaid, in my community health center, which is disproportionately Medicaid, we're at like 50% of the payer mix. But in most facilities and most provider systems, Medicaid is somewhere between 5 to 20% of the payer mix. And so from a provider perspective, you still have one foot in the fee-for-service canoe and one foot in the capitation canoe. And we know that that is not ultimately going to shift actually day-to-day operations from a provider perspective. It's very difficult as a provider to think about doing one thing with one patient and another thing with another patient. That's not going to be a viable path forward until and if all payers are ideally aligned. And so certainly a hope for this program is that by catalyzing at the state level, we are able to also influence other payers across the state to start to capitate primary care as well, such that the experience of a provider, hopefully in the next few years, will be much more well situated in the capitation bucket and can start to do many of the, much more of the move towards team-based integrated primary care that Doug was talking about. And we'd love to see Medicare do the same.
So, thank you, Nate. So talking about, speaking of a multi-payer approach and imperative, Crystal, can you share with us PBBH's new strategies and what is the level of promise you think they hold for righting the ship here on the payment front?
Sure. So at the Purchaser Business Group on Health, we've been doing, through a program I lead, the California Quality Collaborative, a lot of technical assistance. And to take a step back of this, we have brought stakeholders together for a really long time, and we're thinking it's plans, it's purchasers, it's providers, it's patients, to kind of rally around what are our common priorities and how do we support the delivery system, but it's always been around technical assistance. And after a great investment from CMS and the Transforming Clinical Practice Initiative in California, we said, great, we know how to identify high-performing practices. We know how to, what it takes to move them there. But how are we going to scale this? It's still a small number on this long list. And it was in February 2020. We met in person the last time. We had no idea about the train that was barreling down at us. But we sat in a room and said, we have got to figure out how to scale this. And what is our biggest barrier? And you think of a group of all kinds of stakeholders, the one thing they could agree on, it was payment. It was payment, right? And I'm a QI professional. I've been in these practices changing practice, not payment. And I remember going to someone, but aren't these folks in the rooms the one that sign the contracts with each other and actually pay each other? Don't they have some control over this? So then the train hit us, right? But we took that moment and kind of leveraged that history of collaboration to say, let's shift gears a bit and let's go bigger picture. And let's set some standards for what we call advanced primary care, right? How are we going to define it so it's common across everywhere? Because you can Google advanced primary care and you got 5 different versions just to start. But then we went to, okay, but how would we know it if we saw it? And to this measure alignment piece is like, can we come up with a concise set? Narrow and parsimonious was the quote that we used. We're still working towards getting towards meaningful, right? But we looked across all of the payers, national and statewide, and said, can we come to a common agreement of things that are more outcomes-based, right? Less of the processy check the box, but really drive towards, right, controlling patients with diabetes and their hemoglobin A1C, blood pressure. We went to patient experience. We went to depression remission, right? These high-level pieces to know that, right? We know that social determinants, you're going to need to address that to actually change those outcomes. And it's not just a check the box and a quick, process improvement. But this bigger picture of, we also share a delivery system. And any practice you go into, that I go into when I'm working with them to improve, right? They are paid by all of these folks. And for one of those payers to change their payment really doesn't change the business model, right? It doesn't allow them to change the clinical model, much less sustain it. So we share this delivery system. And then we had the catalyst of COVID and said, okay, let's come together. The Nason report came out and they said, it's time. We have a path forward around payment. I hear anecdotally from the health plans of they want to do this, but they don't want to be the first one to step out and do it. They certainly don't want to be the only one because it's actually not worth the investment then because it doesn't change anything. It doesn't have the impact. So I said, okay, how about we hold hands and jump together, right? And so we brought folks together, payers, and we leveraged work that was happening amongst the purchasers in parallel of aligning their contracts, their payment, right? How do you cascade payment? You start at the top with the purchasers. And we had some real vanguards in California, and I'm gonna call out Covered California, our state exchange, and you'll hear from them later today, of putting into contracts these expectations around primary care, building in measure sets, right? Building in transparency about spend, about performance, about the adoption of value-based payment models in the networks. And they were working across payers or purchasers to align, and we had enough alignment between Covered California, the exchange, the CalPERS, our big state pension employers, to say there's enough there that the health plans start to see it and the payers start to see it. Okay, we see the writing on the wall. At the same time, we had some legislation that we were working through to actually set cost targets in the state and inspiration from 17 other states, so we certainly weren't the vanguards in that. But that was coming, and so we said, okay, let's come together, let's do this. I am impatient. I appreciate Dr. Grundy, but I am not patient. And I said, Cal, how about we actually take some time and do this now because we just can't wait any longer. The system is on the verge of collapse. We are, to your point, adding more and more to primary care, raising expectations and not paying them more. So let's talk about a payment model. Blue Shield of California had been piloting one, and I think had some challenges doing it on their own, but some promising things. And they said, okay, we're willing to come and share, and how do we actually build upon this and get common agreement? So after a bunch of discussions, and a lot of people said, plans will never come together and agree voluntarily to this. We actually have 7 payers, 6 of which of those are the largest health plans in the state, have come together to agree to work together through 2025 to scale advanced primary care. And this means they are committing to transparency on spend, on performance, on adoption of payment models. Regardless of purchasers asking them, they're gonna put it out in the world. We're gonna build a statewide system to get that data out there. But not just the transparency, then we're gonna change the payment model, and we are in the midst of designing a hybrid payment model from the Nason recommendations. And then they asked the question, would it be crazy if we piloted it together rather than independently? So we're in the midst of also designing that implementation. I never thought I'd have 6 health plans around the table co-designing how to implement a payment model. Blows my mind. But then more importantly, instead of divvying up pennies, we actually need to increase the investment in primary care. So I feel like this was a huge commitment from them to say, we are gonna move the needle. We are gonna be transparent about where we are, and we'll work towards doing that, but then we're also gonna increase the investment. And I have to say, for any payer that is not hitting double digits in the percent of spend on primary care, your money is not where your mouth is, right? You are not really invested in health equity and primary care. We have got to not just pay pennies and discuss how we divvy up pennies. It's useless. So they've committed to that investment, and then in parallel, thank you. So we can't have a conversation about a payment model without talking about how much we pay them. And so that's a big task, right? It's not an easy task. And then the last piece is how do you come together to actually transform the system and guide them with a real emphasis on behavioral health integration and health equity. And that ties back into how we're being transparent on our performance when those measures are stratified and being held accountable. So they are together, they are discussing, which I feel like is a big step forward, and actually planning together. And we're gonna start to see this manifest kind of more publicly in 2023. We have piloted this concise measure set that is at the practice level. We're trying to figure out how do you measure at the practice level. And so we have been piloting that across at least 3 million patients and 1,000 practices, I think, at this point. So we'll be able to share that with folks of what we're able to bring from that. One, measures are applicable, what doesn't work, of trying to get to that set. But I have to say, I just want to put a plug in. We're working with measures that we're used to working with. We looked at what's common across the sets. We need greater investment and more meaningful measures. So we still struggle with, we want to have better measurement. We're not sure how we get there. And so I open that up to other folks about how do we start to take, I think there's promising things out there. I mean, I'm thinking of Becca Etz, right? And celebrated last year of what she's doing, but how do we take this to scale? We can innovate, we'll keep innovating, but it's time to take it to scale. And then on my one last thing, because I feel like the segue is, as purchasers, they came to the table and said, we are committed to paying more for primary care. We're just not gonna pay more for total cost, right? And I was a huge hurdle to get payers to accept that, and they're moving forward with that. And while many of the purchasers work with plans, they are also looking at direct contracts. And so you see purchasers coming together in a collective way, parallel to what the payers are doing. So PBGH members, purchasers, and some big national names out there have come together and just released, starting with an RFI for direct contracts for advanced primary care, and seeing, they want to get a sense of who out there can actually provide a high level of care and show us the data on it, on the performance, as well as the total spend and that accountability piece. So you're going to see more and more purchasers putting in the same contract requirements, same benefit standards to drive that alignment that cascades through the system.
Thank you, Crystal. And so, Nate, that's a perfect segue. Can you share as succinctly as possible, so that we have time for questions, what Crossover is doing, what your experience has been, what traction you're getting from purchasers in your direct contracting?
Yeah. So my name's Nate Murray, and I'm the co-founder of Crossover Health. We've been around for about 12 years, and it's really nice to be in a room of like-minded lunatics that applaud payment reform around primary care, because it's so needed. And I'm in the commercial space, and so for everybody here, it seems there's a lot of discussion about Medicare. It's certainly an important field, but do not leave us commercial providers behind. We are trying to fight for payment reform. But Crossover Health, we started in a little tiny town called Aliso Viejo, California, right next to Laguna Beach. And my two partners and I got together, and we were just disgusted with the fee-for-service model. All of the narratives that you've heard today, we were just frustrated, because at the end of the day, you can't deliver good care. Good care is comprehensive. It's multi-stakeholder. It includes a primary care doctor, a behavioral health specialist, physical therapy, health coaching, and care navigation. And so to build that foundational model, we said we're going to start our own practice, and we're going to do direct primary care. It's really, really hard. And so we put up our shingle, opened our practice, and no one came. And so it's really difficult for providers. I have a lot of empathy for them that try to go do it differently and kick against the grain. And so then we thought to ourselves, where can we go and get paid differently? We actually went to a life insurance company because we knew none of the existing payers had any interest in changing the status quo. We went to a life insurance company. They didn't really have any interest. And then we went to large self-funded employers. And they had a massive motivation, maybe not for the same reason that we're all in this room, but they had a massive motivation to attract good talent and deliver strong primary care. And we said, we'll go with that. If you believe in that, we'll go with that. And from that, partnering with people like Apple and Meta and Amazon and Comcast, these large employers, we were actually able to go serve a population of people in this format of advanced primary care, where you have a care team that panels up to take care of a specific number of patients under a fixed fee payment model, where you have multiple specialties in the same room that are all focused on delivering this quality of care and this population health model. And so that's what we've been fighting to do, working with these commercial, large, self-funded employers. But ultimately, we have a very narrow spectrum of people that we can serve. And our goal was never really to serve the people exclusively at Apple or at Meta and the fulfillment center workers at Amazon, but it's really to impact the foundation of primary care in this country. And to get there, we have to pivot this payment model. That's where it starts. I think one of the challenges that we face in this room is that there's lots of shiny objects to go after. We deal with SDOH every single day. It's heart-wrenching. The things, we don't get a choice. The things that walk in our door, a flat tire, a flooded home, can wreak havoc on families, right? And they just walk right in our door. And thankfully, we operate under this fixed fee model where we can actually serve these members. But if you just focus on SDOH, or you just focus on this one quality metric, and you don't fix the payment model first, nothing will change. absolutely nothing will change. And so our focus has to be on fixing payment. And for the payers in the room, it does require an investment. We've done a small demonstration project with Aetna on a prospective basis for commercial members in Seattle. And what we found there with working with Aetna, the biggest challenge is that the mechanics of the claim systems, right? These massive systems that are processing millions and millions of claims, billions of claims, it's really hard to pivot. And unless those claim systems can start to pivot, they can make an investment to pay those prospective payments, everything that we do in value-based care is going to have DNA of fee-for-service associated with it. And so at the end of the day, you're still going to see some of these questions. You're going to be tied to those 15-minute visits and anchored to that type of transactional medicine. Just real quickly, I was speaking with Crystal, and really appreciate the work that Crystal and PBHH is doing, but speaking in Chicago, and I get on a plane after I left there, you know, when you get on, I have 4 boys, and my wife and I, right? So we got on the plane, and we're listening to like what they're telling us to do, and they always tell us that we need to put on our mask first. And as a parent, that is the most foreign thing that you would ever do if you've got kids. Of course, you're putting on your kids' mask first. You're making sure that they have oxygen first. And then, of course, airline people, they're kind of smart. They fly planes a lot, right? So they know that, like, if parents don't have their mask on, they're totally worthless, right? And I kind of feel the same way about payment reform in primary care. If we don't put on the payment mask first, we can't fix all the other things. We can't save all the other lives. We have got to adjust that payment and allow for these practices, the fiscal space. This actually was in the Nason report. The fiscal space to allow these medical groups to innovate under that. And so hopefully we'll have that opportunity in this discussion, and please reach out to me. I hope to be a part of this going forward now that I've missed the ball for the last decade plus, but hopefully be a part of these conversations to drive payment reform.
Thank you, Nate. So let's kick this up a notch. I just want to share a woke moment I had this morning. I read a Washington Post article about the gun safety movement and learned about how for decades we've lived this, right? Many of us. It seemed hopeless that there would ever be rational gun control, either legislatively or in practice, regulatory-wise. It was hopeless right up until it wasn't. And what interviewees in the article pointed to was an accumulation of rage. That, you know, you begin with hopelessness, and there's kind of a learned helplessness about it, and people who don't help you, the non-facilitators, weren't the focus of the rage for a long time. It was the gun makers or the NRA. But once the rage turned to the people who were not facilitating gun safety, like congressional members, right, and regulatory bodies, that is when movement happened, when the circle of rage widened. And I don't say these things lightly because those are violent terms and that doesn't sit easily with me, but I think that people might mistake the polite applause in the room whenever we talk about payment policy for a willingness to wait to see what comes around the corner. And I want this conversation to be about, I would ask each of the panelists to speak about, you've talked about what you're doing. What would you like to see some other sector in healthcare do to move payment reform forward? And I will start, I'll lay out my wish list, and I throw this primarily at Doug, but really for anyone, is right now on the Hill, there is massive negotiation and lobbying going on around what to do with the 4.5% expected reduction in the physician fee schedule payments, right, for everyone. And in exchange for Congress doing away with that 4.5% hole, what could be the gimme? Could it be a new expert panel to look at the fee schedule in Medicare? Could it be something else, right? That is what I would like to see. I would like to see a statement, right, in legislative action that says we have reached the tipping point. The focus of rage is widening. So let me throw that out for you guys to react to. And what is your top wish list item for what somebody else should be doing? Doug?
So maybe I'll start just by saying the negative 4.5% reduction. It was mentioned earlier today. So one of the main learnings coming to the federal government is when Congress writes a law, there is certain, we have certain flexibilities sometimes, but we don't have certain flexibilities other times. And so this in particular was an area where we did not have flexibility, and it's written into law. I will say another no-no that I've learned since coming into this position is that I can't say what Congress should or shouldn't do. And so I can't answer that directly as much as I would like to. And so let me just maybe make that a little bit broader and just say that when CMS comes out with a regulation, it's so high level and it's at the 10,000-foot view. And I also see patients on a weekly basis. And so translating what's in those regulations into like actual patient care is not what people at CMS are like experts in. And it just working with states, working with innovators, working with providers, working with plans, like translating what we're doing we can like set certain guardrails in certain ways with a lot of these regulations, but everyone in this room is directly delivering that care to patients. And so ultimately what we're trying to do is change how care is delivered. And we've talked a lot about the fee-for-service payment system and our high-level goals, but I brought in that to like, what would we like to engage people with? Like that's kind of our focus, and we'll continue to do events like this. I'm excited to hear people's thoughts. We know that some information is coming into the chat, and so after the action plan comes out too, we're interested in engaging and hearing what did we miss, what's good, what should we focus on, and so we really look towards everyone here to help inform that.
Do you have a wish list item?
A wish list item for
what you would like some other actor, not CMS, to do to move payment forward?
I will say what's interesting is that we've created a lot of changes with the shared savings program that I talked about. Mm-hmm. I think it's also a tremendous opportunity for both states and also FQHCs, other primary care practices, to look at these changes. And there's a lot of ACOs forming all over the country. And so far as it makes sense, should a state actually like look at this model and say, hey, let's bring all the payers together, like what we've talked about in others, what Crystal talked about and what's happening in California. Can we get all the payers together and say like, hey, insofar as there's providers that are already joining these models, changing the way that care is delivered from fee-for-service to value-based care, can we combine Medicare and Medicaid? Because that's an even bigger gorilla, and we can really accelerate some of the payment transformation at a state level.
Thanks, Doug. Ryan, what's on your wish list?
So I work for Medicaid. I have the distinct pleasure of being the worst payer in the room at any given time. And I'm sure many of you, myself included, feel that on a day-to-day basis. Ultimately, if we want to talk about advancing primary care in the United States and advancing health equity, we need to decrease the delta, the difference between the rates for Medicaid and everybody else. And Nate, this is not a. This is.
Trying to leave me out again.
No, hang on. This is not a dig on the importance of continuing investment in commercial or in Medicare as well. I think personally we need to increase investment in primary care across the board. But in terms of rate disparity across in the United States and across payers, I think if you're looking at ROI and marginal value of impact, increasing Medicaid rates and potentially, dare I say it, the FMAP would be a substantial.
So those are actions for state legislators and
no,
CMS?
Those are not actions for state legislatures because we do not control the FMAP.
But
the FMAP is controlled federally.
But the FMAP needs to match something.
Yes, exactly. But working in a state that is budget neutral, and most states are, little known fact that I did not appreciate until I worked in state government, the feds can go into deficit, we cannot. And so our state legislature holds us to net neutral funding at any given time. And so there is no discussion about increasing budget unless there is going to be an increased match as well at the federal side. And so you can start the conversation with state officials when you can also say, hey, there may be a way to actually pull down additional federal revenue as well.
Got it. Crystal, your wish list? See, the late folks have the advantage of really being able to hone their wish list.
Yes, M+1, M+1. I want people to understand safety net providers are commercial providers. Commercial providers are safety net providers. They are not distinct groups. In California, the biggest Medicaid program, over 60% of beneficiaries get their care not through FQHCs and county systems, but in small and independent providers that also contract, right? They have Medicare patients, they have commercial patients, they have mixed panels. We only solve for that system when we solve together and give them the resources. And so to that end, my ask is that Medicare, CMS, Medicaid come to the table. And I'm gonna say that, we've invited CMS to the table. No shows. We've invited Medicaid to the table. No shows, though I have to say in California, there's now some interest that they see the commercial side aligning because the folks at the table are the payers that all have Medicaid, have Medicare, right? Commercials. So I feel like we need Medicare and Medicaid to show up to the table and not as the questions I often get is, how do we get the commercial payers to do what we're saying we want to do, but actually to join in real true collaboration and partnership and a dialogue, help us understand the constraints, right? And let's help solve for it as a system and not solve for what one stakeholder wants.
I just want to say I'll be happy to go to any meeting.
Thank you. February 15th.
We're accomplished something today. A commitment.
If I can just,
Yeah.
one comment on Crystal's. We've actually been talking about this in Massachusetts, and one of the challenges, and I see it in the chat, is antitrust. And so creating the venues and the spaces where both payers as well as government officials feel that they actually can engage. Because I will tell you, many of us in state government would like to have these discussions, and our general counsels sometimes tell us that we are not allowed to. And so actually creating the venues and the mechanisms like you guys are doing is a core part of that.
Right, and I just want to point out that with CPC Classic and CPC Plus, we did that convening and our antitrust partners were right there with us, so it's entirely doable. Nate.
I've got two because I got to play catch up, you know. It's been commercials not represented super well, but the first thing is with the payers. My ask of the payers get knocked a lot for being the bad guys, and I think that maybe they deserve it sometimes, but they are also a really important part of this ecosystem. So the first thing is I hear payers talk all the time about value-based care and they really want to do this, but at the end of the day, what inhibits them from my perspective is their inability to actually make a prospective fixed fee payment. I mean, their whole chassis is built on fee for service. And so when you actually dig into it, it's like, oh wait, we can't do that, even though they want to do that. And so there's gotta be an investment. So the payers, I would ask, look at your chassis and your ability to do prospective payments and make the investments to do those things. Otherwise, we're just gonna be doing a lot of talking and there will be no action. The second thing is for the states. What I have found as a primary care medical group is that when I actually go take a prospective payment at the state level, it is very unclear whether I need to go in the state of California, become an insurance company, get a Knox-Keene license. The language that is written in the state regs, Department of Insurance or whatever it may be, is so unclear that when I actually get into a dance with a payer to say, hey, you're gonna pay me a prospective payment, then their regulatory people throw their hands up like, you gotta get licensed in an insurance company. And I'm like, I'm just a little 1,500 provider medical group, and now I gotta go take on all this fiduciary responsibility. I'm not paying anybody else. Everybody's a salaried provider at Crossover. They get paid a salary. We're not doing any kind of payments to specialists or anything like that. And so I would ask the states to make it really clear so we're not in this circular environment whether I need to become an insurance company when I'm just trying to deliver whole person care to a panel of members that want to come get that type of care from me.
So let me just bolster the commercial priority here. I can completely affirm Nate's observations. At Anthem, it would have cost tens of millions of dollars to rebuild that payment, that actual disbursement mechanism. And so we did it in tiny little silos, and it was never very satisfying. But you know, the investment dollars are there. Health plan margins were, I think, the best they've been in a long time, and they've been good for a long time. Last year, you know, in the middle of the pandemic. And also I would affirm that it can be very confusing and terrifying for especially a small group to not know whether they are a formal risk-bearing entity. So I think all of that's true. We've got 2 minutes, and I'm going to throw it out free for all, whoever wants to jump in. You have heard a lot this morning about the new expectations on primary care, and we know that the rate-limiting step is payment. I think we've agreed on that. What action are you most proud of from your organization's perspective in how you have tried to address the mental health crisis and social drivers of health? And I'll go backwards this time. Nate?
Yeah.
Well, actually, free for all. I said
Free for all. So the thing that I am most proud of is creating a place where, I think it was Dr. Grundy or somebody from the panel before, where, or maybe it was a question, they said that people just don't want to go into primary care because it's not a really good profession. And I just feel so proud that we have created a practice environment where it's team-based care. They can work with peers. They're focused on a panel of patients. They're not billing codes. They're getting a salary, and they're happy. That is tremendously rewarding. And I would like to add, because we've created that, all of a sudden, the transactional medicine has gone away, and people who have a flat tire that wrecks their house, that wrecks their health, people who have plumbing issues that all of a sudden now they can't get their medicine, we're able to solve those things. And so, I'm in this for the social good, and I'm so proud that we've been able to create a construct to help providers find a place to practice their art.
Anyone else?
I can jump in. So I'm really excited about these advanced investment payments and ACOs. I think it's a game changer. They're prospective payments. It's not fee for service. It will really could unlock a lot of flexibility at the provider level to address social needs in ways that haven't been addressed before. Food, housing, transportation. It's one of the first times we're saying in Medicare, you can use this Medicare dollar to address social needs. And so I'm really excited about the potential, and I think it can unlock a lot of ingenuity at the provider level.
Well, any last thoughts? With that, let me just thank the panel for your energy and all of the amazing work that each organization is doing. And also, as importantly, I think for pointing out the barriers, and I think instead of calling them barriers, I'd encourage us to call them the tails that shouldn't wag the dog. So a disbursement system that was built in the 1970s shouldn't be wagging the dog, right? The political force that is everyone else in the fee schedule shouldn't be wagging the dog. That's not what we're talking about. So with that, thank you all, and Mary, on your way to rating.
Hi, Mai. Nice job.